topic, the second part of the spinal cord. I am Dr. Prashant. So as we have finished with what exactly the white matter consists of, it consists of the tract. The tract is nothing but the collection of nerve fibers within the CNS which is having same origin, course and the termination. If this tract, the tracts have some different names like fascicular or lemniscus. These tracts which are rounded, or collection of these tracts which gives a rounded appearance, in a cut section it gives a rounded, like round like section is a fascicular, and those bundle of nerve fibers which are ribbon like are lemnisci. These tracts, they are named by having two components. The first name will be its origin and the second name will be its where it terminates. For example, corticospinal tract. The name corticospinal means the tract it has originated from cerebral cortex and terminated in the spinal cord. So it's named as corticospinal. Likewise, how will you name the one which has arisen from the spinal and into the cortex? Spinal cortical. Correct, but the nerve fibers which ascends to the cerebral cortex from the spinal cord, they terminate in the thalamus, as the thalamus is a relay between this tract. So it's named as spinal thalamic tract rather than being named as spinal cortical. Okay, now let us see further what are the classification, how they are classified. These tracts are classified as, they are classified as descending tract and ascending tract and ventral tract. Descending tracts are nothing but which descends from the cerebral cortex down towards the spinal cord. The ascending tract, they are nothing but the sensory tract which ascends from the spinal cord above towards the cerebral cortex. Intersegmental, they are the one which interconnects this, so they are the association fibers, having the association one. Looking at this picture here, you can see there are few descending tracts which are enumerated. There is a corticospinal tract, tectospinal tract, rubrospinal tract. So this corticospinal tract, it begins in the cortex, it passes through the midbrain, pons, medulla and then into the spinal cord. So it means that the study of this tract is not only concerned with the spinal cord, but we need to study it at the different levels, medulla, pons and the midbrain. So today what we are going to see is, so regarding few tracts, we are going to see its the origin, we are going to see its termination, its course through which it passes, and the functions of its tracts. I think few of these tracts, I think the tracts is over in physiology. Still, if it is over, still it will be like a part of the revision for you. Let us begin with the descending tract. To start with, the corticospinal tract. The corticospinal tract is also known as pyramidal tract. It's pyramidal tract because it arises from the pyramidal cell of cerebral cortex and it descends, it arises from pyramidal cells of cerebral cortex and it descends via the brainstem and then into the spinal cord, and in the medulla oblongata it lies in the pyramids, so it is called as a pyramidal tract. This corticospinal tract is divided as lateral corticospinal tract and anterior corticospinal tract. The lateral corticospinal tract is the crossed fibers and and is the cross pyramidal fibers, and anterior corticospinal tract is uncrossed pyramidal fibers. Let us have a look over this picture. So this picture, it shows the descending, that's the motor tracts, and the ascending tracts. Here you can see the descending tracts. In half of this region here you can see the ascending tract, which so here in this spinal cord section you have to look it out where these tracts lie. Like the lateral corticospinal tract, they occupy the column of the spinal cord and they lie on the sides of the posterior horn. Then comes the rubrospinal tract, which is lying just in the front of the lateral corticospinal tract. The other one, the anterior corticospinal tract, it will be lying on the sides of anteromedian fissure. Next to it lies the tectospinal tract, vestibulospinal tract. These are a few major tracts what we are going to study regarding the descending tracts. So we were now concerned with these two tracts, the lateral corticospinal and anterior corticospinal tract. The lateral corticospinal tract, as I said, it origins from the cerebral cortex. Where exactly from the cerebral cortex? That is from the area number 4 and area number 6. So these two areas in the cerebrum are concerned with the voluntary movements. So the area number 4 and the 6 of the cerebral cortex of the opposite side of the cerebral cortex gives the origin for this lateral corticospinal tract, and the pyramidal cells are present in this. That's why this tract is called as a pyramidal tract. After its origin, it passes through the bundle of the fibers within the cerebral cortex, and that region is called as internal capsule. You may forget the name. It's not possible to memorize everything at this moment, but as we proceed further with the cerebrum, medulla, brainstem, so it will be easier for you to recapitulate everything. So I was the fibers which takes origin in the cerebral cortex, they descend via the internal capsule fibers which are there in the cerebral cortex. Then they descend then comes the brainstem. So after the cerebral cortex, the fibers, they descend via the brainstem. The three parts of the brainstem are midbrain, pons, and the medulla. So they cross either of this. So where the location of these fibers needs to be known when we are studying the midbrain, pons, and the medulla. In the medulla, they will be lying at pyramids. So the location of this tract in the medulla is called as pyramid, and after the pyramid they cross to the opposite side. Here you can see they are crossing to opposite side. So these fibers, after crossing, they occupy the lateral corticospinal tract in the spinal cord. So maximum number of fibers they cross. Few fibers they remain uncrossed and they run vertically downwards, and they lie along anterior corticospinal tract. After coming, they will be coming right into this region of lateral corticospinal tract. This is the lateral corticospinal tract, and here it is the anterior corticospinal tract. Now the fiber has to come to the neurons. So neurons is located, the motor neurons are located in the anterior horn of the spinal cord. So they come and relay with the neurons which are located in the anterior horn cells, either directly or through the internuncial fibers. From here the motor supply is given. So this is about the lateral corticospinal tract. The main function of this, it controls the conscious skilled movements of hands, fingers, feet, and the toes. Now tell me, in case if there happens some lesion to this tract somewhere here, what will be the result? Yes, definitely there will be a paralysis. Note the point, the lesion of the motor tract is divided as in the two ways: upper motor neuron lesion and lower motor neuron lesion. You will come across this when you will be talking about some clinical aspects. The upper motor neuron lesion means the lesion above the motor neuron of the spinal cord, anterior horn cells. So lesion above it, anywhere above, either in the midbrain, medulla pons midbrain, or in somewhere in the cerebrum. So that will be the upper motor neuron type of lesion. And the lesion at the anterior horn cells, or after that, or in the peripheral nerves, those will be called as lower motor neuron type of lesions. Now, I said the lesion to this will cause the paralysis. The point to be noted here, the paralysis seen in the upper motor neuron type of lesion is spastic type of paralysis. It is nothing but the muscle has gone into this becomes hyperactive, and the tone of the muscle is increased, leading into the spastic paralysis. Why this happens? Upper motor neuron influences the lower motor neuron. So when these fibers are cut, the inhibitory signals from above, they are lost. So the lower motor neuron, they gets hyperactive, and the tone of the muscle is increased, leading to the spastic paralysis. Let us move to the next tract, the rubrospinal tract. Rubro is for the red. So red. The red nucleus of the opposite side of the midbrain. The red nucleus is present in the midbrain. And before this, we studied pyramidal tract. The next whatever tract we will be studying are extrapyramidal tract. They will influence the motor activity in some way or the other. So the rubrospinal tract, they get this, the red nucleus in the opposite side of the midbrain get its supply from the cerebral cortex and also from the cerebellum, get its influences from these two areas. The fibers from the red nucleus cross to the opposite side, right in the midbrain, and descend downwards through the spinal cord to lie along the lateral white column of the spinal cord. So the rubrospinal tract will be located in this lateral white column of the spinal cord. You can see here at this region. Further, they terminate in the anterior horn cell of the spinal cord. That's the motor neuron. What is the focus? It's the unconscious coordination of the movement. Let us move ahead with the next part. It's the vestibulospinal tract. The vestibulospinal tract takes origin from vestibular nucleus of the same site. So here, this is the vestibular nucleus. It is present in the floor of the fourth ventricle, which is nothing but in the region of pons and the medulla. So this vestibular nucleus has an influence from the cerebellum and from the inner ear. So is the name vestibular. This vestibular nucleus sends the fibers, sends the tracts, descending tract along the same side of the spinal cord and lies along the anterior white column. So in this picture you can see the vestibulospinal. Sorry, it's not clean. It's not that sensitive. So here you can see the vestibulospinal tract on the anterior column, which is the larger one, the violet color structure. Yes. This vestibulospinal tract is concerned with unconscious maintenance of posture and balance. Moving to the next part, the tectospinal tract. Now the tectum is present in the superior colliculus of the opposite side of the midbrain. So here it's the midbrain where the nucleus is seen. So this superior colliculus, it receives the influence from the eye, from the visual. It gets the visual stimulus and it crosses to the opposite side, descends along the spinal cord to occupy the anterior white column near to the vestibulospinal tract. So again the violet color structure you can see along the anterior median feature, yeah, right here, just beneath this is the right here is the tectospinal tract. The function of it is it controls the movement of head, neck and arm in response to the visual stimuli. To give example, suppose you are walking by and your friend suddenly throws something on you, and in a response what you do, you suddenly try to protect from it. So it's by this action which happens is via this tectospinal visual stimuli you get, and you suddenly flex, you turn your head, you try to flex your arms. So that's the tectospinal tract. Okay, that's all about the descending tract. So in short, we have studied about the corticospinal tract, which descends from the cerebral cortex. Then we have studied about the spinal tract and vestibulospinal tract. Now let us move ahead with the ascending tracts. The ascending tract, they conduct the impulses from the periphery of the brain cord. One of the ascending tract is lateral spinothalamic tract. Now this lateral spinothalamic tract is concerned with carrying a pain and the temperature sensation from the opposite side of the body. Let us see the origin of this tract. The first order neuron of the lateral spinothalamic tract is located in dorsal root ganglion. From here, the axons, they relay in the substantia gelatinosa cell of the posterior horn. After this, the nerve fibers, they cross to the opposite side by passing a one segment level above to the opposite side and occupy the lateral column, where it gets right here. So in this section, in this picture, half of this part you can see this half part, you can see the ascending tract part, and here you will see the lateral spinothalamic tract. Yes, right here it's a lateral spinothalamic tract. So the fibers, as I said, it ascends upwards. The fibers, it ascends upwards and they relay in the thalamus. As I said before, the thalamus is the relay center for all the sensory modalities. So after relaying in the thalamus, the fibers ascends to the cortex, where the area number 312 is located, which is concerned with the sensation. Area number 312 in the cerebral cortex. So this is about the lateral spinothalamic tract. Likewise, the lateral spinothalamic tract, as said, it carries pain and the temperature. Likewise, there is anterior spinothalamic tract. The anterior spinothalamic tract, this blue colored one, you can see it has the first order neuron in the dorsal root ganglion, again in the substantia gelatinosa, where it gets relayed and crossed to the opposite side to come along the anterior column. So this is okay. So along the anterior column, you can see here, right here is the anterior spinothalamic tract. So this anterior spinothalamic tract carries the light touch pressure from the opposite side of the body. Here I have mentioned about the nucleus of the thalamus. The details of this nucleus we will study when we see the thalamus. It's the ventro-posterolateral nucleus, VPL, ventro-posterolateral nucleus of the thalamus. So these are the two ascending tracts, anterior spinothalamic and the lateral spinothalamic. Lateral spinothalamic is concerned with the pain and the temperature, and anterior spinothalamic is concerned with light touch pressure from the opposite side of the body. Both of these tracts will cross. The point to be noted here is when they cross to the opposite side, they lie along this anterior white commissure. Anterior white commissure, here you can see. Now, there is a condition called syringomyelia, in which the central canal is dilated and it damages the neural tissues surrounding the central canal. When the neural tissue surrounding it gets damaged, it also damages the tract which crosses to the opposite side. So this is the tract which crosses to the opposite side along in the region of this commissure, this anterior white commissure. You can see there is a loss of sensation of pain and the temperature. Pain and the temperature as it crosses on this side, but the other sensation like proprioception, which is carried along the posterior column, is preserved. So we'll see it again after during the applied aspect. Let us come to spinocerebellar tract. Spinocerebellar tract, as the name suggests, it goes from the spinal cord to the cerebellum. So it has its origin from the posterior horn cells of the spinal cord. But here, in my previous lecture, I said there is a nucleus dorsalis, where this proprioceptive fibers. I said the nucleus dorsalis is concerned with the proprioceptive fibers, relay center for. So this spinocerebellar tract, these fibers coming here, they relay at the posterior horn cells at the nucleus dorsalis. After that, it passes along this lateral white column and ascend upwards through the inferior cerebellar peduncle to the same side of the cerebellum. The anterior spinocerebellar tract, it relays in the nucleus dorsalis, crosses to the opposite side, come to lie along the lateral white column and ascends upward, and again cross back to the same side to pass via the superior cerebellar peduncle into the cerebellum. So this is about the spinocerebellar tract. The function of this tract is the unconscious kinesthesia or proprioception. So you know what the proprioception is. In my previous lecture I said about the proprioception. It is concerned with the joint sensation, muscle sensation, vibration, 2-point discrimination. Now let us demonstrate how this proprioception acts. Now what you can do is raise both your hands. With your right hand, touch the tip of a left index finger and then touch the tip of your nose. Yes. Now close your eye and try touching it. It's possible, but it's very difficult. Now, what you do is raise your hand, only one hand, and flex your wrist joint. Now extend it. Close your eyes. Flex your elbow joint, and again extend. You did it correct at that joint. How did you do that? So it's because of the sensation, joint sensation, the proprioceptive receptors which are present in the joint. So those are the proprioceptive fibers which are carried in the vestibular tract. This is the unconscious proprioception. Next, we'll see the fasciculus gracilis and fasciculus cuneatus. The origin of this is from the dorsal root ganglion of the spinal nerve of the same side, and then the fibers continue along the posterior column. It continues upwards till the medulla oblongata, where it gets relayed in the nucleus cuneatus and nucleus gracilis. After the relaying in this nucleus, the fibers, they cross to the opposite side. They are called as a sensory decussation. This crossing happens in the medulla oblongata. This crossing is called as a sensory decussation because these are the sensory fibers. And we had seen in the pyramids, after the pyramids, the cortical fibers, they had crossed, and those crossing of the fibers are called as a pyramidal decussation, and these are called as a sensory decussation fibers. They cross to the opposite side and then ascend, relay in the thalamus, and go to the sensory cortex, area number 312. This tract, which is called as fasciculus gracilis and fasciculus cuneatus, of which fasciculus gracilis is the medial one and fasciculus cuneatus the lateral one, is also called as tract of Gall, which is on the medial side, the tract of Burdach on the lateral side. It is concerned with, again, a proprioception, but this is a conscious proprioception. The joint sense, vibration sense, 2-point discrimination, and stereognosis. So the fasciculus gracilis and cuneatus, they are concerned with this proprioception, conscious proprioception. Let us see the third tract. We have done with the descending, ascending, and now coming to the intersegmental tract. Intersegmental tract interconnects the neurons of the different segment level. This intersegmental tract are concerned with the spinal reflexes. A few of the spinal reflexes, which includes withdrawal reflex. The withdrawal reflex is also called as flexor withdrawal reflex. So to give example for this, as I explained in my first lecture, it's about if the sole of the foot of a sleeping person is pricked with a sharp pin, the leg is reflexly drawn up. This neural, so you can see here the pin which is shown, my pointer is not moving. So the pin which is shown, it pricks the lower limb, and there happens a sudden withdrawal of the limb. This mechanism, neural mechanism, happens because of this withdrawal reflex. It includes the following. So this is the afferent fibers. This is the afferent fibers which carries the pain sensations, which relay in the interneurons, and from there the interneurons relay to the motor neurons, and it gives a supply to the upper muscles, causing a contraction. This reflex is called as a withdrawal reflex. Likewise, there is a stretch reflex. The stretch reflex is done by the clinicians to elicit the tendon jerks. Now here, when the tendon is jerked, here you can see when the tendon is jerked, the intrafusal muscle fibers, they get excited and they send signals to the alpha motor neurons here, which stimulates the surrounding muscle fibers, which causes it to contract. The contraction of it will create decrease the of this intrafusal muscle fibers. So this reflex which is produced is called as a stretch reflex. The spinal cord is concerned with this reflexes, simple reflexes. Now let us go for the blood spinal cord. The arterial supply is through the anterior spinal artery, which arises in the form of the two spinal arteries. You can see here the two smaller spinal arteries unite to form the anterior spinal artery, which continues up to the filum terminale. The two posterior spinal arteries, they arise either from the vertebral artery or from the posterior inferior cerebellar artery, and they run along the posterolateral sulcus of the spinal cord and they descend downwards. They are further divided into the collateral branches. You can see here the posterior spinal artery having the two collateral branches on either side of the posterior nerve roots. So in total there are 4 posterior spinal arteries on either side, and one spinal artery in the front. So in total these 5 longitudinal channels of the spinal arteries, one spinal artery and the 4 posterior spinal artery, they supply the spinal cord. The posterior spinal artery supply a posterior 1/3 of the spinal cord, and the anterior spinal artery supplies the part of the spinal cord. This supply is influenced by the supply which comes from the segmental artery. The segmental artery is divided into the posterior radicular and the anterior radicular artery. They supplement the supply of these channels. Let us move further with the venous drainage. There are 6 longitudinal venous channels, 2 median longitudinal and 2 anterolateral and 2 posterolateral channels. All these venous channels, they drain into the intervertebral venous plexus, which drains further into vertebral, posterior intercostal vein, lumbar, sacral. Cranially, thus venous channels, they drain into vertebral venous, basilar venous plexus. Let us come to the applied aspect. As I said before, the syringomyelia. The syringomyelia is nothing but the fluid in the central canal. It increases, leading into the damage to this area, causing a damage to the tracts which are crossing from here. So mainly the tracts which are crossing are anterior and the lateral spinothalamic tract. So this modality of sensations are lost. But so there is a bilateral loss of pain, temperature, sensations below this lesion, but the sensation, the proprioceptive sensation carried by the posterior column remains intact. Brown-Sequard syndrome is also called as a hemisection of the spinal cord. This is the spinal cord. Here you can see it is a cut in the half of the part due to an external injury caused leading to the half of the damage of the spinal cord. So when the hemisection occurs, hemisection of the spinal cord occurs, the effects noted are ipsilateral. Note this, it's a ipsilateral upward motor neuron type of paralysis due to the involvement of pyramidal tract. I say ipsilateral upper motor neuron type of paralysis. What does it mean? It's the paralysis of the same side of the pyramidal tract, because the fibers they cross above in the medulla oblongata. So when the damage is occurring to the spinal cord at the same side of the pyramidal tract is lost, and there is a ipsilateral loss of proprioceptive sensations due to the involvement. The proprioceptive sensations also cross right in the medulla oblongata, and we had seen that they are set as the sensory decussation when they cross in the medulla oblongata. That's why there is a ipsilateral loss of proprioceptive sensations in the posterior column. And the point to note is contralateral loss of pain and the temperature sensation. Why contralateral here? Because we had seen that the fibers crosses the fibers carrying pain and the temperature, they are the lateral spinothalamic tract. They cross along this anterior commissure, they cross to the opposite side in the spinal cord level itself. So the damage to the spinal cord will cause the contralateral loss of pain and the temperature due to involvement of this spinothalamic tract. So these are the basic three important points in which are the effects of the hemisections. Tabes dorsalis is a syphilitic degenerative lesion of the posterior white column and the posterior nerve root. So it's the posterior column is damaged. So which fibers are affected? It's the posterior tract of the fasciculus, tract of Gall and tract of Burdach, also called as fasciculus gracilis and fasciculus cuneatus. It is affected. So definitely the proprioception is lost, the conscious proprioception is lost. Person becomes ataxic. Ataxic means he sways when he closes his eyes. This is the conscious proprioception. Thank you.